Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. So welcome again, everybody, to today's program, Cancer and the Heart, What You Should Know. We've had Dr. Medepalli do this program a couple times and have always got really great positive feedback. I think it's an interesting topic so many people are wanting to tune in for, so we're happy to have this back and with Dr. Ninan joining us. So I'm Katie from Cancer Support Community Atlanta. If this is your first time joining us, we do invite you to check out again that website, cscatlanta.org. There you can see a wide variety of the programs that we offer. You see support groups there. Sorry about that. We have support groups led by licensed mental health professionals, and those range from some diagnosis-specific support groups to a general weekly group. We also have really great stress reduction classes like yoga, tai chi, nutrition seminars we host monthly, and those are led by an oncology dietitian with Northside Hospital Cancer Institute. I also want to highlight that we do cooking demonstrations. So if you haven't been to our physical space, we do invite you to come and check out a live cooking demonstration. Those are really fun. And at the end, we all get to eat. So it's a really great experience. And of course, education programs like these. So for additional information on any of these programs, again, please feel free to check out our website, cscatlanta.org. I'm excited to welcome Dr. Ninan as the moderator of today's program. Sorry, still letting some folks in. Dr. Mary Ninan is a board-certified hematologist and medical oncologist with Georgia Cancer Specialists, Northside Hospital Cancer Institute. She's an active member of the American Society of Clinical Oncology and American Society of Hematology. Dr. Ninan has participated in clinical research and published in national meetings and journals. Her primary interest is in the treatment of hematologic malignancies, breast cancer, and supportive care in oncology. She's an active member of the Hematology Steering Committee and Quality Research and Therapeutics Committee. She is a hematology-oncology expert for Northside Hospital Cardio-Oncology Program for International Cardio-Oncology Society. So welcome, Dr. Ninan, and I'm going to pass it off to you to get us started.
Thank you, Katie. So good afternoon, everyone. It is with great pleasure that I introduce Dr. Lalitha Medepalli. So Dr. Medepalli is a non-invasive cardiologist and cardio-oncologist at Northside Hospital. She's a very experienced cardiologist, and she currently serves as the medical director of the cardio-oncology program and the School of Echocardiography at Northside Hospital. Dr. Medepalli has made significant contributions to the field by developing clinical algorithms that enhance performance and standardize hospital procedures. Her work promotes the use of clinical guidelines in cardio-oncology, ensuring high-quality patient care. She has authored numerous publications on cardiovascular diseases and imaging and is an International Cardio-Oncology Society board-certified cardio-oncologist. So I invite Dr. Medepalli to present this important topic that discusses the cardiovascular risk of cancer therapies. As we are seeing more advances in the management of cancer, the number of survivors are also increasing, and hence managing the cardiovascular risk during and after treatment becomes critical in patient care. So Dr. Medepalli will be providing an overview of the cardiovascular risk assessment and management during and after cardiotoxic cancer therapies. And before we get started, just wanted to remind everyone to use the chat function for any questions, and we will address them at the end of the presentation. So welcome, Dr. Medepalli.
Thank you, Dr. Ninan, for this introduction and kind introduction, and Katie and CSC Atlanta Support Group for giving me this opportunity to discuss about cancer and heart disease, how it intersects, and it's extremely important to be aware of the top two leading causes of death in United States share several common risk factors. So the issue is advances in cancer treatment. A lot of advances are happening in cancer treatment, very, very fast pace, and these oncological therapeutics are improving the survival, but at the same time, also there is some increased risk for cardiovascular mortality and morbidity. Cardiovascular risks are associated with this cancer treatments. Long-term surveillance is also very crucial to detect late onset cardiac complications, not just surviving through the cancer, but long-term risk is also there. So knowledge about this cancer therapeutics, what it takes to get the cardiovascular health is knowledge is power, will be very, very useful for our cancer patients to live longer and healthier. Thank you, CSE, for giving me this opportunity to try to educate all our patients and families and survivors and support staff to be a part of a collaborative team so that patients can live longer, healthier, and with reduced cardiovascular risk. Goal of this is to cancer survivor without developing heart failure or cardiac complications is our goal for cardio-oncology discipline. So if we look at the statistics and from United States MMWR morbidity mortality report, the top two causes of death are cancer and cardiovascular disease. So it is very important to know why these two are the leading causes of death and what we can do to reduce these risks so that patients can live longer and healthier. And if we look at the picture format, the heart disease is #1 cause of all death in United States and all over the world, and also the cancer is leading right behind the heart disease. It tells us something already, why these two are going together. So that means some of the risk factors which are associated with heart disease are also possibly the risk factors of cancer. So there is an intersection for development of heart disease and cancer, first of all. And once a patient gets into this cancer box, then there are also the underlying subclinical heart disease may get exacerbated because of oncological therapeutics with treatment or lifestyle changes, and then as cardiovascular risk increases, and so then the both go hand in hand again upwards. So that's why it is very important for us to understand the risk factors which may be associated with both these diseases, so we can implement strategies to risk reduction and improve the overall morbidity and mortality. In picture format, it's like a 70-80 rule. By the age 70% of all population have cardiovascular disease. By 80% of all cardiovascular men and women have cardiovascular disease. So as we advance in age, the cardiovascular risk goes up and cardiovascular prevalence go up. And if we look at the cancer statistics, the top two of the 10 leading causes of cancer, the top two leading causes of cancer, both in men and women, is prostate cancer in men and breast cancer in women. So these two cancers, if we look at the cancer distribution, what is the age when the cancer hits? If we look at the median age at diagnosis, 60, 60, 60, 60, 60. And, and if we look at the prostate cancer and breast cancer, again, around 60. So the cardiovascular disease and cancer risk are both at, the risk is around 55, 60, the risk goes up. So that brings up to the, if we do the risk factor reduction, even before cancer, as support staff and family members, or if a cancer diagnosis is made, if we reduce the risk factors, both cancer recurrence and the cardiovascular risk goes down. And if we look at the cancer survivors in the United States from 1970s, where the drug called anthracycline was initially found and detected, and from then, if we track the survivorship it's a very high projectile, exponentially improving. That is fantastic news for our cancer patients. The survivorship is exponentially improving and going up the pipeline. This is because the number of trials happening for cancer treatments is also extremely high compared to all other specialties. For example, cardiovascular specialty versus oncology specialty, the number of research phase 1 to phase 3 trials is increasing, so the number of oncology treatment options coming out of the pipeline are rapidly coming out. So along with that, so this is translating also to the survivorship. So along with the survivorship, all these oncology treatments sometimes are being used as not just first-line treatment, they are second-line treatment. Sometimes I see patients are on 5th or 7th line treatment. So they are already, they have been exposed to already 5-6 different varieties of cancer treatments. Each has their own intrinsic small risk of cardiovascular toxicity. So added up, sometimes I see patients in combination chemotherapy on an anthracycline and group of drugs called anthracycline and another group of drugs called immunotherapy. They are in combinations. Sometimes I see patients with subsequential. They get chemotherapy and then they're now lined up for surgery and radiotherapy. So it's addictive and sequential, and it's various aggressive cancer approaches, treatment approaches to get the patients into survivorship. So that is translating into this survivorship. So in that, at the same pace, we also need up with the cardiovascular health, as we had already seen, cardiovascular and oncology, the risk factors go up. So if oncology treatments are getting up, the cardiovascular care has to go up to match that. Otherwise, there is a big chance that cancer patient survivor will translate to cardiovascular mortality. So that is what data is showing. That is when the awareness started rising up. And in 1996 or so, the first cardio-oncology paper came out of Italy. And since then, several cardio-oncology specialty clinics sprung across the state of, across the world, United States, North America, Canada, and Europe, and several Africa, South America, everywhere. So as these advances are happening in the last decade, at least over 100 publications are happening every year with new data coming out of cardio-oncology, cardiology aspects of oncology care, giving more and more insights for us as cardiologists to be very top-notch supportive treatment and or co-treatment, co-multidisciplinary treatment with our oncologists to help navigate through this cancer survivorship. According to National Cancer Institute, there are at least 14 million survivors. They were alive in 2012, and it doubled by 2022 in 10 years. 10 years, the 30 million became 22 million. So the survivorship is rapidly increasing. 67% of adults diagnosed with cancer today will be alive in 5 years, and 75% of children diagnosed with cancer today will be alive in 10 years. Fantastic news. And this number is rapidly increasing as well. When we look at the cancer survivor survey, 7 years into 7 years, 33%, 1/3 died of heart disease. And so 50% died of cancer. So the cancer recurrence right behind is a heart disease. So that is why we have to be very, very careful while going through oncology treatment, also side by side, pay attention to the cardiology and cardiovascular health. Even radiotherapy or chemotherapy or both sequential or, they both can cause cardiovascular complications. So survivors of pediatric cancer, when we look at the siblings study, patients who, for example, two children in the same family, that means same environmental conditions, if the one sibling had a pediatric cancer and went through the treatment, for example, leukemia, lymphoma, they got radiation therapy. When we look ahead, by the reach 15 years ahead, 15-fold increased lifetime risk for heart failure. So that means if a child got radiotherapy or chemotherapy at age 15, by the age 15, 30, they're finding cardiovascular disease in that patient 30 years of age, when siblings are not finding that in the same living environmental conditions. So that means they're at increased risk of heart failure compared with the matched cohorts in the same control group in the same family atmosphere. And if you look at the older patients, the pre-existing cardiovascular disease is a very powerful marker for them to be at risk for heart failure. So survivors of aggressive non-Hodgkin's lymphoma have a 17% incidence of clinical heart failure at 5 years. So because they go through intense chemotherapy regimen with aggressive chemotherapy and sometimes even radiation. So if we look at the graph, when we compare patients without cardiovascular disease and cancer survivors, whereas cancer survivors with cardiovascular disease, when we follow them up at 8 years, if we look at this pictorial graph, their survival is going down. So that means there is a huge gap to fill. If we only can identify these patients with cardiovascular disease and optimize their health, we can push that up, cancer survivors into better survivorship. So mitigating the risk and improving the survival is our goal. If we identify these patients, intervene appropriately by both lifestyle changes, non-pharmacological and pharmacological intervention, the survivorship goes up with better, less cardiovascular heart failure risk. So, and this is a very, very useful picture graph format to understand why cardiology needs to be, cardiac risk factors are important in oncology care. For example, if we look at the genetic predisposition, patients' family history of strong family history of premature CAD, or if they have pre-existing classic risk factors like hypertension, high cholesterol, smoking history, diabetes, excess weight, or lifestyle, not exercising and weight problems and things like that, or prior history of heart disease. If they have CAD, PAD, peripheral vascular disease, or heart failure, valvular heart disease, if these are all already pre-existing, that will reduce the cardiovascular reserve already. And now comes with cancer treatment with its own risk with cancer treatment. Cancer being a cancer itself is a risk for cardiovascular disease because the overall health goes down, their lifestyle changes happen, they're not mobile as much, they're weak, and during the cancer treatment, and the cancer-associated cancer therapeutics also will have their associated some risk, 2 to 3%, what have you. So if we take care of all these associated problems, so the heart has to deal with only one cancer treatment. So that is our goal, is to educate the patients about the classic and risk factors and optimize the medications if they are on already pre-existing cardiovascular disease and we have certain drugs which have shown in studies to be more helpful, called cardioprotective therapy, rather than and optimize the cholesterol level. And some medications can drop the heart function. We monitor the heart function closely and try medications which are guideline-directed medical therapy to improve the heart function and support the cardiovascular system. So mitigating all these coming at the same time as comorbidity to cancer treatment. So heart cardiovascular system has to just deal with this cancer treatment and come out as a less risk and, more into survivorship, more healthy. So we don't want two hits at the same time. That is the goal. Try to optimize cardiovascular pharmacological and non-pharmacological intervention during their cancer treatment. So that's where our my brief intro for cardio-oncology is.
Yeah, I mean, thank you for that great introduction regarding the scope of the problem and how we need to assess the cardiac risk before treatment. As an oncologist, when I see a new patient where I need to plan the treatment, I obviously look at these underlying conditions and then see what sort of kind of cardiology help I need even before I start. So sometimes we need to get a baseline echocardiogram, EKG, and we have to monitor those even in patients who do not have a cardiac dysfunction. But then in patients who have underlying lifestyle risk factors or lifestyle disorders, it becomes very important. And I think it also becomes important depending upon the type of chemotherapy we're going to use. And like you alluded to, the combination chemotherapy versus radiotherapy, all those factors into the risk and the prognosis of the patient. So I think it'll be a good idea to kind of discuss about all the chemotherapeutic agents and how they will factor into your decision making.
Yeah, that's a great question. So in 1970s, anthracycline, some people call it as Red Devil, even I think used heavily. I think Dr. Ninan and Mary, you also use these a lot, right? For your blood cancers and even
Yes.
triple negative breast cancers and leukemias, lymphomas, Hodgkin's lymphoma, non-Hodgkin's lymphoma. They're a part of regimen in several treatments. So, because it's really hard on the heart, especially with comorbidities and risk factors, as we talked about, and cause nausea, vomiting. But, it depends on anthracycline. Risk goes up with the dose. The higher the dose, the higher the risk, not just during the treatment, but in long-time risk. So that's why when I see my patient, I immediately write down what is your lifetime dose? Try to get that and try to put yourself in which risk category so you can be aggressive. So as we see, as the dose goes up, the risk goes up, the incidence of heart failure and risk goes up. And, later on, the targeted therapy, uses Herceptin, trastuzumab, pertuzumab, and several VEGF inhibitors, several targeted therapy now exploded the survivorship. What a great achievement from oncology world. So, there people are, advancing into very rapidly to survivorship within a year. That's great. My mom is a survivor. That's how I got into cardio-oncology. She received anthracycline for triple negative in 2009, and she just collapsed one day in India when she was walking and with acute pulmonary edema, heart failure, and all risk she had was hypertension. So that's when I thought, it's just not. It's with this group of patients, we need a lot of TLC, tender loving care, not just one time, once a year kind of check, more consistently watching out for heart failure symptoms, risk factor modification, optimizing medical therapy. They have long-term risk, not just that time risk during oncology treatment. And they have a VEGF inhibitor. Now they're targeting I see a lot of those patients from especially gynecology, oncology, GU setting, and some GI cancers. They use Avastin and several other drugs, Lenvima. Before they are only infusions, they go to their oncology infusion center, get their treatment, okay, done. And then if any problems, they call their oncologist. Now they are on oral agents. So who are they going to call? They're going to call, the patients are going to call their primary doctors or go to ER, or for any reason the treatment is stopped for upcoming endoscopy or some other procedure, then the blood pressure bottoms down. So it is very important to have a good knowledge of the side effects for the patients and empower themselves to manage. And then we are now using immunotherapy oncology with boosting their the patient's immune system itself and trying to attack the cancer, so that have some intrinsic risk, maybe 2% risk of, depending on the risk factors, associated risk factors, or they may have 1 to 2% or more, depending on their where they stand. But that can be a very big risk. If it may not happen, if it happens, it can be life-threatening, like myocarditis, inflammation of the heart muscle, and things like that. And CAR-T therapy, and bone marrow transplant, and radiotherapy, and new cellular therapies with the heart racing and blood pressure drops, and there are several drugs with varying risk from 3 to 20%. So why this much gap? Because how you intervene, how you manage the associated risk factors, and how do you manage the blood pressure, hypertension, cholesterol, positive stress management support, and with CSE support group, discussing, talking about survivors, and identifying, when I have a patient who is a very strong advocate for survivorship, recently interviewed also with one of a big international cardio-oncology society. She presented with pleural effusion, fluid around the heart, as cancer. So when she got shortness of breath, we thought it was cancer, when it actually heart failure is happening. So heart function dropped to 20%. So we have to identify that, not just thinking that, okay, oncology, the cancer or treatments or cancer spread or something is happening because of the symptoms, to identify the heart failure symptoms and approach immediately to do simple tests and find out if that is cancer. Like anthracyclines, they can cause heart failure, and cisplatin can cause arterial thrombosis, blood clots, and drugs called 5-FU, it can cause heart, usually used for GI cancer. It can cause spasm of the coronary arteries, so chest pain should not be neglected. And all these endocrine therapies, breast cancer patients with AI, and prostate cancer, ADT therapies, they can cause like cholesterol disturbances, blood pressure disturbances. And, as Dr. Ninan said, some drugs need, even normal heart, they need to monitor the EKGs periodically, because it can prolong how the heart pumps and relaxes. The time it takes can cause arrhythmias, especially if electrolytes are not balanced. And radiation therapy, bone marrow transplant, I don't want you all to leave here saying, okay, my God, all these drugs are, I'm going to have a heart failure or something like that. It's just, risk can be less than 2% if you have knowledge and be proactive, compared to 20% no knowledge and neglect. So the main takeaway for this lecture is knowledge is power. Try to know the symptom signs, risk factors, keep as much as possible lifestyle modifications, eating healthy, stress management, take the support, family support, or login support, and, talk to people. And, that time will pass. And I see so many survivors in the office. That is such a celebration. So then just staying healthy and keeping up is a very important key. Just a picture format. It's from Canadian Cardiac Oncology Network. Dr. Susan Tent, very powerful advocate for cardio-oncology. She's an oncologist. So she used to be in Canada, now moved to Duke, I think. But that's her, took from her one of her programs. Can cause arrhythmias, heart function dysfunction, blood clots, high blood pressure. With VEGF inhibitor group of medicines is a significant problem. Lenvima, Avastin group of drugs. 5-FU, we reported a case from Northside. Since last 2-3 years, we published at least 5 or 6 papers from our own cardio-oncology department here at Northside. So these all can happen. So just staying abreast of having a knowledge about this, and approaching the doctor, on time, and, either oncology, primary care, and hey, I'm on this oncology drug too, kind of thing, to look out for, will make a big difference in survival.
Yeah, I mean, it's well said in the regard in with regard to the identifying the problem and then referring to the cardio-oncologist appropriately. It's just that the idea would be to prevent any of these from happening while the treatment is ongoing, because with these major complications, that will often lead to treatment delays or treatment interruptions, which are something that we try to avoid as much as possible. But as you rightly pointed out, it's not like we're trying to scare anybody with the cardiac toxicities, but it's being the awareness and appropriate diagnosis at the right time is the key to keeping patients healthy so they can complete the treatment. For example, in breast cancer, when we are trying to do a curative and treatment in triple negative cancer, we don't want any breaks in treatment. We really would like to stay on schedule if possible. So close monitoring and timely notification of the new symptoms and all that will make a big difference.
Absolutely.
Yeah. And I'm truly blessed to be with a system that has a great cardio-oncology program, because if I have a problem, I know how to reach you and text you and call your colleagues. So that'll be, I think, a great overview. It'll be good to have a great overview of what Northside's program looks like at this juncture.
Yes, absolutely. Our goal is to not to delay. That is our main goal, is to not to delay the treatment. So we have several patients in common, Dr. Ninan. When she suspected a coronary artery disease, maybe a associated problem, she timely got the patient in halfway through that treatment. And then we intensified cardioprotective therapy. And as soon as the treatment 4 cycles were done, I brought the patient back and we intervened. And so patient survived the cancer and survived the heart, prevented heart attack, heart failure. So our goal is to intensify medical. We have fantastic medical in our armamentarium as well. We are very blessed with cardiology research, and we very, very good medicines available to support while to temporarily postpone if emergent needs are required for interruption, to avoid interruption. So that said, so our administrators, Northside Hospital, we are very, very blessed to have had the same vision when I approached in 2020, moved to Northside System from Gainesville. I approached the administrators, they jumped right on. At that time, there were 14,000 new patients every year they see in Northside System. Now it's up to 15,000. So we are only second in the nation to receive that many patients seen through our NHCI. So there are, at that time when I started, there were 46 cancer infusion centers across the state of Georgia, and there are 55 cancer centers. When I interviewed, they said, I want to start cardio-oncology larger program. In a smaller program now, and they said, state border is your limit, but actually I see patients across the state border now. So that is so fantastic. Our NSCI has so they jumped right on. We started the task force for a year, and we thought we needed a good cardio-oncology program, and we have specific protocols in place. Our main goal, as Dr. Ninan said, not to interrupt the cancer treatment unless absolutely dangerous for the patient. So our goal is to get the patient in. If a call is placed to general cardiology, many times they may not understand that, okay, if I come next available 2 weeks, 3 weeks, 2 weeks is too late, sometimes. So we need to jump right on access to the program. That is the main key, is to get the patient in quick and try to, the time is very, very important here, and improve cardiovascular outcomes along with our oncology survival. So that's where, instead of staying in oncology niche and then cardiology separate, both dealing separately, our goal is to combine these two, oncology and cardiology, together and make it as a team multidisciplinary discipline called cardio-oncology. That way, as oncology treatment is happening, we support cardiology and vice versa. And then we successfully come out as a good survivor. That is our goal. And the questions we wanted to address here was who needed to be referred for a cardio-oncology evaluation before treatment. These are our discussion points when me, Dr. Ninan, and all other pharmacists and administrators we met once in a while for task force, is who requires these, how do we follow up treatment is online, PI measures, quality measures. Do we need to, especially the cardio-oncology plays a significant role when I get multiple calls daily or texts or offline, patient is here in my office. This is the problem. Shall I go ahead, give the treatment? I said, go ahead, give the treatment and get the patient in within 1 week and try to. So we don't want to, we get interfere with the, what are the alternative approaches. And we use some testing, like Dr. Ninan said, we use cardiac history and we get the cancer treatment history. How many, that's very important for us to obtain records. Because which line of treatment patient already got exposed to anthracycline, now getting radiotherapy or, now getting immunotherapy, or that is important for us where the heart is right now in exposure standpoint, lifetime, what the heart had seen. And we get the blood pressure, cholesterol, A1C, and I get baseline markers, cardiac sensitive markers, high sensitivity troponin I and BNP, which gives a very, very high timeline. If in case patient gets symptoms later on, if we check a troponin, patients may have these mildly abnormal already because they're anemic, what have you, some comorbidities. So if the patient already starts treatment and they go up and some symptoms happen and they check, and we don't want to blame on toxicity and back off on the treatment. So that is my main reason for having these, not that I'm going to expect a normal. We have a baseline and some symptoms happen, may or may not be due to cardiotoxicity, will be a good guidance for me to check, renal failure patients, sometimes the troponin may be very high on dialysis, and then later on some immunotherapy or some other treatment, and then troponin goes high. No, this is not from my baseline is high, so we don't have to worry. Let's see what is the main reason for this symptom. These serve as a baseline, very good associated risks assessment and cardiac markers, EKG baseline. And sometimes, as Dr. Ninan said, echocardiogram baseline, and some treatments also require echocardiogram on every 3-month basis to check, to detect heart dysfunction ahead of time so that they can be intervened quickly. So so we want to see pre-treatment and during treatment and also into survivorship. And we want to have a combined oncology and cardiology task force working on it in Northside system, mainly focusing on quality. And we try to look at the records. We try to look at the regimen. And sometimes patient may have a primary cardiologist. I get that all the time, 80% of the time. And then once the oncology part is done, I hands off to the primary cardiologist. And we are actively looking into cardiotoxic effects, new cancer treatments and research and registry. Our goal is to have a dedicated availability, increase accessibility, and scheduling issues not to be a big hurdle for the patients. So we are trying to keep clear line of communication. We have an excellent support team from NHCI. I have literally every oncologist cell number with me. So I try to, something I see wrong, I immediately communicate right away. So effective communication is extremely important to facilitate accelerated care. And surveillance, long-term surveillance, we are planning, eventually our goal is to have a surveillance clinic too for all our survivors for risk factor modification emphasis and cardioprotective therapy. And this is a very, very good, came out from Vanderbilt, which I also kind of discuss in my almost every patient room to be kind of ABCDE, 5 fingertips, to check off every day, being aware of your risk factors, blood pressure, cholesterol, constant check, cigarette smoking, diet and exercise, and along with A1C and cholesterol checks following with PCPs. And sometimes we may have to do an echocardiogram and cardiac markers. So that's what we're working, as you and me are as a part of this program at Northside from cardiac stand viewpoint?
Yeah, I mean, rightly said, these are some of the things that we at baseline need good assessment. And most of the patients who come in with cancer are in that age group that they already have some of these risk factors. And tobacco cessation is something we address in all patients, regardless of risk or chemotherapy regimen. And then others like diabetes management. So there's like a multidisciplinary involvement in the care of these patients. And especially in cardiotoxic drugs, it becomes a higher acuity that we have to identify these problems. So most of the time I tell my patients to keep a BP log and bring them at every visit so we can review it and kind of work with a cardiologist. And if it's not to the point where we can get it controlled, that's when we get cardio-oncology involved in most situations. Yeah, so that's like a good segue into when we should refer a patient or when we should start looking for cardio-oncology. I see several questions regarding that on patients. When should they involve cardio-oncology in the care, and when should they start looking for a cardio-oncologist?
Yes, that is, so watching out for the symptoms of any heart failure, like blood BCD, blood pressure, cholesterol, diabetes, exercise, keep constant. Sometimes the medications for hypertension may not be the right medicine for that. For example, a VEGF inhibitor group of drugs, you can't throw in any medicine atenolol to work or something like, we need something which works on blood vessels. So certain group of oncology treatments need certain group of cardiology meds. So sometimes a medicine called ibrutinib for lymphoma, we can't use cardizem. People verapamil, they interact. So it is important to have the knowledge of not only the cancer treatment, but when cancer diagnosis is made, trying to know the drug and what are the potential side effects, looking out for shortness of breath, leg swelling, heart failure symptoms, fluttering, dizzy, any unusual things which is consistently happening, not one day, maybe a good approach to consult the oncologist. Usually they are the first line responders or primary care, and can always ask or directly to CSC approach. They'll have contacts to refer immediately. This is a very important slide. Actually 10 years ago, and I can't believe what it will be this age of when we have so many good drugs. The sooner we interact, the better the survival. If heart failure symptoms happen, if we get in board and get on the treatment, and in 2010, 64% had complete reversal. And now with our excellent guideline-directed medical therapy, it's not repeated, but I'm sure there will be a lot more. So the later it happens, the cardiac cell death may happen. So it is important to sooner the diagnosis, accelerated care, and with appropriate therapy, it can be completely reversible and no damage can be prevented. So that's very important and we developed these guidelines for our hospital system. For example, a patient is on anthracycline, work on risk factors. All oncologists have access to these algorithms. And once they see the heart function dropping, or we have an advanced technology called strain, it dropping, we recommend consult. So we have guidelines in place from various previous published studies and consensus statements. For example, patient is on targeted therapy like Herceptin and trastuzumab. They do 3-month echoes, and if the heart function drops less than 53%, or a thing called strain, which drops, or signs or symptoms of heart failure, take a break, put red, and immediately send to cardio-oncology to optimize therapy. So that's what we have. Several major drugs algorithms in place for so to kind of when to refer kind of patient standpoint and from physician standpoints.
Yeah, we use this algorithm all the time in the sense that for HER2 target therapies, there is all the patients are supposed to get echocardiograms every 3 months, and we closely monitor the EF. And if there is any drop, like you pointed out, or if there is a change in the GLSS, that's when I reach out to cardiology. And I get a lot of questions about what GLSS means. Sometimes a well-educated patient will read through this report and will be asking me, so could you please go over that in a little bit more detail? That'll be great.
Yes, so GLS is a strain in advanced technology. We have a very powerful measure called strain imaging. What we do is with the echo probe, patients, if they had echo, they'll understand that it's like a transducer, like pregnant patients, they'll have the probe on just the echo machine probe, just like that, the same probe we put right above the heart and the chest, and we send the sound waves. So when we send the sound waves, we are sending the sound waves, the heart is squeezing in and out, in and out. When it's squeezing, the heart muscles get the sound wave and reflect it back. So the tissue is reflecting that. We are tracking that speckles reflecting back, coming back to us. So when the toxicity happens, usually it starts happening as a patchy, more so in the wall of the heart, inner wall of the heart. And then, so when this starts happening, the other parts of the heart squeeze comes in to help and keep the overall heart function, what we call as ejection fraction, normal. So looking at ejection fraction sometimes can be misleading, thinking, oh yeah, ejection fraction is normal, but subclinically toxicity may be happening. That's where the strain drops, normal. So we get this by drop this many, sound waves, and the speckles, the sound waves reflect us back to us, and we do the computation and we generate this the fantastic algorithm already pre-established, and this is how we get in a normal scan. So normal scan should be all red and between 18 to 22, but if we see patches of it is dropping to yellow and other colors, then we know that blue, then it is not good, that part. Even though ejection fraction is normal, the strain is dropped, that means part of the heart is already getting tired. So that means there is a big chance some risk factor is happening, which we are unable to see. So we have to look for it, maybe high blood pressure, stress, or rapid heart rate, or, diabetes uncontrolled, or more likely high blockages to the heart arteries. So we find that problem and control the risk factors, optimize the medical treatment, and the strain picks up back again. 18 to 22 should be normal. It drops to 14 and may drop to 18 again, rather than 14 and 12 and the drop to minus 14, and the next 3-month echo will be heart function drop next. So we're not doing any. So strain is a good red flag you can on-go treatment because the heart function is not dropped, but we need to, before the next treatment comes, look out what is happening. Something is happening to the patient, which we need to intervene and take care of. Otherwise, there is a big chance this is a subclinical heart dysfunction, futuristic view that the heart function will drop. So it's a warning sign, red flag for us. So those are our top 3 takeaways from this. I think we are approaching time. So mainly before treatment, during treatment, and into survivorship, we want to identify through oncology therapies with potential risk factors and stratify them: low risk, intermediate risk, high risk. We recommend our oncologists to send medium and high risk, especially patients, ahead of time, so that we can optimize their treatment ahead of time before even they start their chemotherapy. And during treatment, if we want to minimize treatment interruptions and avoid cardiac complications. And into survivorship, keep an eye on cancer survivor is always at risk for heart disease compared to others, because at some point the heart was intensely stressed. Their cardiovascular system was put to stress for some certain period of time. Their overall reserve goes down. So we want to keep an eye on that survivorship, risk factor reduction, and monitoring with lifestyle changes, constant reminders. Sometimes just a reminder will help look out for themselves and survive cancer without developing heart failure or cardiac complications is our goal from Northside Cardio-Oncology discipline.
Thank you so much for that excellent presentation. I'm pretty sure folks have a better understanding of the side effects of cancer therapies in terms of the heart and how to identify and how to approach them. So that was great. There are several questions. One of the questions here is, how many cardio-oncologists are there within Northside cardio-oncology program? And for people who are outside the Northside system, how can they see a cardio-oncologist, and what would be the process to do that?
We have a cardio-oncology program at northside.com. We have a web email ID where they can send. We used to have a dedicated navigator to reach out. Now it's a larger program. We have cardio-oncology spread apart. We developed certain quality measures to be up to beat and up to date in cardio-oncology emerging technology. So they can just send the email, and we go by two different ways. One is by proximity, as we were discussing, Dr. Ninan yesterday. So proximity, if the patient lives in Canton, we have cardio-oncologists there. Or sometimes physicians prefer this particular physician only, so sometimes patients don't mind driving and coming. So I have several of those myself too, and I'm sure all other cardio-oncologists have, due to their whatever preference method is. I see a lot of bone marrow transplant patients coming from across the states for that BMT, pre-BMT, during BMT, post-BMT, and until 100 days, they follow me, and then they move out to Savannah and things like that. So either they can email that or call that number, or my contact is that our office number. But when they call, when they send an email, they can specify, I live in Canton, or I live in Blairsville or Gainesville, do I have a cardio-oncologist close by? Or they can message that line, or they can ask their oncologist, or they can ask or directly call me, our office. So I'll be glad to. That is my interest. 80% of my patients are oncology patients. So I block 4 spots until 24 hours before. Unless the 24 hours before it's not filled, they don't open to the general cardiology patients. That's how I give high priority to the oncology patients to get their access care quickly as possible.
Thank you. So there are several questions regarding cardio-oncology management as a survivor if they did not have the cardio-oncologist following them during their initial treatment. So what I would say as an oncologist, and Lalitha, you can add to this, if you have already completed your treatment, you should definitely have a regular follow-up with your primary care physician or oncologist for survivorship care. Based on which treatment you received, there are specific survivorship care guidelines and how you should be monitored. And you should always watch for cardiovascular risk factors, avoid smoking, limit alcohol, and all those good lifestyle factors. And if there's any cardiovascular symptoms or signs, it should be addressed quickly, and it should be brought to the attention of the treating physician that you have received the specific medication in the past, because there are some late toxicities that we need to be aware of. So always follow the survivorship guidelines, and your oncologist should be providing you with a survivorship guideline at the end of treatment. And to that point, there was a question regarding 5-year survival. So 5-year survival means after finishing up treatment, are you alive at 5 years without the same cancer? So are you cured of your cancer? That's what 5-year survival means. And the 5-year cardiovascular toxicity is whether did you develop any cardiovascular complications at 5 years from the treatment that you received initially. So that's what that means. Did you want to add anything to that, Lalitha?
Yeah, that's great. Yeah, with anthracyclines, radiotherapy, usually the risk starts around 5-year mark. The guidelines call for even no symptoms screen if they had chest radiation to get a coronary artery, some screen, some testing, heart scan, and an echo, and go from there. So each has their own specific survivorship guidelines, which the oncologist will be giving, or any question they can make an appointment and be sure to address those.
Yeah. So there is another question regarding TKI. So TKIs do have cardiac toxicities that Dr. Medepalli has discussed. So most of these patients, they need EKG monitoring and then echocardiogram as needed, and close monitoring of cardiac risk factors like cholesterol. And so I typically tell the patients who do not have any cardiac issues to have their annual cardiac risk assessment with their primary care. If there's any issues with their EKGs or blood pressure or echocardiogram, I promptly refer them to a cardio-oncologist. That's how I approach the TKI toxicity. So that is something. TKIs do have cardiac issues, so that is another class of drugs that need close monitoring. And if you look at the list of TKIs that we have now, the list is growing every day. So it's just the number of drugs that are in that class, it's just growing every day. So I think there are other questions regarding prior chemotherapy and prior radiation. So again, survivorship care is very important. Even though you finished your treatment several years ago, all these medications have long-term toxicities. So be sure to manage the lifestyle risk factors and have adequate annual or at least semi-annual follow-up with your primary care to monitor your blood pressure, your sugar, your all your other lifestyle risk factors.
Yeah. A CDE is a good way to remember cigarette smoking, cholesterol, D for diabetes, E for exercise.
Yeah.
Well, that, being aware of A and B blood is it's easy and very easy way to keep the lifestyle and risk factors under control.
Yeah. Great. Awesome. That was a great talk. And there were a lot of good questions from the audience. And I think Katie put up where there should be feedback. If there are any feedback or quotes, then please share with her. Thank you again, Dr. Medepalli. That was a great discussion.
Thank you, Dr. Ninan and Katie and CSC and all.
Yes, thank you both. Thank you both so much. That was a great presentation. Of course, if you want more information for Dr. Medepalli, there's that cardio-oncology program information. And then if you'd like more information on getting in touch with Dr. Mary Ninan, you can visit the Georgia Cancer Specialist website. And for additional information on any oncology support programs, we have some, again, really great virtual and in-person programs available. Visit our website, cscatlanta.org, and you can also see past recorded programs there as well. So thank you both again. This is always such an interesting topic. I always learn more. And thank you for everybody who is joining us. We hope to see you all again soon.
Thank you.
Thank you, Katie.
Take care.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.